presentation updated the classification of MDS. First of all, could you analyze the important differences between the edition of 2017 and edition of 2022 MDS classification?
Hi, I'm Rami Kumrukji. I'm Vice Chair of Malignant Hematology Department at Moffitt Cancer Center. I think this is an important question because in 2022, now we have two classifications, the WHO and the ICC. The WHO, in the newer version, have revised some of the categories. It went to first what we call molecularly defined subcategories of MDS. So now we have, in addition to deletion 5q that existed in the 216 version, we have SF3B1 MDS as well as biallelic P53. So we have three categories that are molecularly defined. That's new in the WHO 222 criteria. Then based on the morphology, the WHO, still maintained ring sideroblasts subtype if they are more than 15%. They renamed a little bit MDS with increased blast. We used to call it MDS with excess blast. Now it's called MDS with increased blast type 1 and type 2. And finally, they introduced two newer categories. If patients have less than 5% myeloblast, but the bone marrow is hypocellular, so we have a hypoplastic MDS. And if the myeloblasts are increased and there is fibrosis, then that's MDS with fibrosis. So those are really the major changes between the 216 and the 222 criteria.
Implementation of a team S170 used the classification of MDS in WHO 2022 and ICC 2022 to analyze the prognosis and survival of patients with MDS. Could you share that in detail?
Absolutely. So obviously we try to provide evidence-based or data-driven, evidence in attempt to harmonize those two classifications. It's not good to have two different classifications for one disease, and the idea is to bring them back together. A classification should reflect the biology of the disease or common features, not just the prognosis. So we tried to collect a large data set between Europe and USA. We were able to get together almost 7,000 MDS patients, which is probably the largest MDS database conducted to date. And we looked at those things. So we clearly saw that, for example, MDS with SF3B1 has the best outcome, and it's correct in both groups. Biallelic P53 has the worst outcome. There are some differences between the two that we probably need to bring them together. And deletion 5q has good outcome. Then we saw that ring sideroblast without SF3B1 is not as good as SF3B1. So probably that can be dropped from the WHO. While a presence of dysplasia, multilineage or single lineage dysplasia did matter. So that's from the ICC, so we are keeping it. There is a little bit still uncertainty about the best cutoff on the blast percentage. So that's yet to be determined. And then finally, the fibrosis or scarring in the bone marrow, we were able to show that it is important and it's associated with worse outcome. So at the end, we are trying to harmonize those two classifications and conceptually think of the classification in a different way. So I presented like some, suggestions for or proposals for future classification where we can think of a chronic phase MDS, those that have low blasts, deletion 5q, SF3B1. Then a more aggressive MDS or accelerated, like if the myeloblasts are increased, the P53, the MDS with fibrosis, and then finally the AML from MDS.
Okay. If you please talk about the advances of MDS treatment at this EHA conference.
Right. I think this year had been really a breakthrough in the management of lower risk MDS particularly. So we have two studies presented at this EHA. Yesterday we heard the presentation on the Myelodysplastic trial in lower risk MDS. This is a randomized phase 3 clinical trial that showed Myelodysplastic was active, leading to transfusion independency in almost 40% of the patients. Durable responses, more than, like the average duration is more than a year. Responses even in patients that are needing a lot of blood transfusions at baseline, and suggesting that the treatment could also alter the natural history of the disease because we are seeing reduction in the allele burden of certain mutations. So I think this presentation and the subsequent publication will hopefully lead to the approval of the drug. So that's one of the major things in the lower risk. The other one we are going to hear to this afternoon on luspatercept, a study called COMMANDS study. Again, a randomized phase 3 clinical trial will be presented at the plenary session today, randomizing patients between erythroid stimulating agents and luspatercept in the upfront setting. We heard some of the data presented at ASCO meeting a week ago. The study met the primary endpoint. There is doubling to the responses than erythroid stimulating agents, more durable responses. So this also could be a practice-changing clinical trial. So I think the major advancement this year had been mostly in the lower risk MDS for treatment anemia. We heard today also during the same session some kind of interesting data about total oral therapy for higher risk MDS with oral decitabine cedazuridine combined with venetoclax. Again, small study, 40-50 patient. But showing promising activity, a very good bridge to transplant. So I think in the future we may treat our patients with a total oral regimen, even the higher risk. And finally, in the same session, we heard a little bit more about lenalidomide for deletion 5q, that sometimes discontinuation could be a possibility, although like in the past, the classical dogma was to continue the treatment all the time, but now it seems that there is a subset of patients that treatment could be discontinued, which will have practical implications in everyday practice.